Yeah, it's good.
All right. I'm a respiratory therapist, so what I'm going to do is, if you had your packet, you should have received a handout. I'll just kind of go through, the reason I said to look at that, it'd give you some pictures on what I'm talking about. Basically what we do is we usually work with the patients that are generally the most sick. And we work with groups that have problems with their lungs or with their heart. Now, one system works with the other system, so if you start having problems breathing, you know, your heart has to take over and try and make up for that problem and vice versa. So they're two very closely connected. I might say from the start that you guys maybe feel uncomfortable sometimes in situations, but you play a very important role in the healthcare team. So, you know, spiritual health plays a big role in physical health. So, even though sometimes you may be uncomfortable, you definitely have a place there. Okay. We work with all the chronic lung diseases. We give breathing treatments. Some of you may have become familiar with people that have treatments. We work with oxygen. We are a member of the Code Blue team. Everybody know what the Code Blue team is? We do the emergencies. We do the life support equipment, the respirators, ventilators, whatever terminology you've used. We also do some diagnostic things like blood gases and pulmonary function or breathing testing. But if you look at the first page, you'll see a picture of a nasal cannula. This will give you some indication of what you might see as you go into the room. This is the very basic level of oxygen supplement. Just a device that fits like a cowboy hat into the nose. And we supply the supplemental oxygen to the patient that way. And as you flip through to the next page, the vending mask, everything gets a little bit higher in the amount of oxygen we're delivering. And you go down through to the next one with the non-rebreathing mask, and you can see how it's starting to look a little more complicated. Well, that means that the actual amount of oxygen that we're delivering is also going up. And then you go to the next page and you'll see a picture of a nebulizer. For those that are unfamiliar, we deliver aerosolized medications to the lung in various lung diseases to help relax the airways and move secretions and so forth. And you'll find asthmatics in particular use these at home. On the next picture, you'll see a resuscitation bay, and that you would find in situations for cardiac arrest, Code Blue team, where we manually breathe for the patient. Now you can see a little mask on that device which we hold over the face and actually squeeze the bag to force air in and support ventilation in that manner. The next page you see is a respirator or ventilator. That you'll see at the bedside of ICU patients that we support or have to completely take over their breathing. And the machine itself, it looks kind of detailed, but what we do is we actually put a tube down the throat into the windpipe and then the tracheal tube. And on that tube, it has a little cuff that seals off the windpipe. And that way we can force air in and out and breathe for the patient. But because of that sealing off that windpipe, the patient will not be able to talk. So normally when you talk, air has to go out through your windpipe and your vocal cords vibrate and you get noise and you make words. Well, with that being closed off, if you see that situation, the patient won't be able to talk to you. under most circumstances. There's a few tricks that we can play, but generally speaking. And in those situations, you may find some patients that are comatose or not with it. And it may present awkward situations on communication and so forth. But I would suggest to you that you would communicate normally as if they were awake or could talk, because we don't really know what they understand and what they comprehend when they're sedated or comatose. So we would assume in normal conversation that maybe they might understand what you're saying. And then you have, on the next page, you have up in the top a tracheotomy. And that is a tube that also goes into the windpipe. When we have a patient on a machine for an extended period of time, we have to take that tube out because of the irritation. So they would actually open a hole into the windpipe through the neck and stick a smaller tube in. And that way, it's a lot more comfortable for the patient. It's easier for us to manage. The patient could still eat if they have to, etc. But again, it's sealed off so they won't be able to talk. All right? And then you go to the next picture and you see a face mask, commonly referred to as Cpap. You'll see that in the hospital as well, but many people will use that at home for sleep apnea. I'm sure every family has somebody that has sleep apnea that uses the Cpap machine to sleep at night. So the same thing, if they come in here, we have to supply them with the Cpap to have them sleep. Now we have a little bit more technology in that line that we can also use for supportive measures as well, that we try and use before we go to an intubation or placing the tube and putting on a ventilator, because it's less invasive and it doesn't open you up for a lot of side effects. Okay? So that's kind of a really quick overview. Questions, I don't really know what specifics you may have concerns about or have questions about. I'd certainly try to answer. Yes?
Larry, how many people do you have in your department?
We have about 18 people, but about half of them are part-time.
And you have someone here 24 hours?
24 hours, yeah, 7 days a week, plus a whole bunch extra. Anything else?
If people are on a CPAP at home, I mean, do they bring their own with them, or
Yes.
you said you had the supply?
We have a system, but we encourage, if you have one that you normally use every night, we encourage you to bring it along and use it. Anything else? Well, thanks.
Yeah.
Have a good day.